Well, thanks very much, Jonathan and Charles, for inviting me to be part of this symposium. It's great to have such a terrific audience here this morning. I'm going to follow on Mike's terrific talk by addressing some specific drugs that might be used in managing complex patients, particularly those who have extensive drug resistance. And what I'm going to do in my talk is to first review again what the guidelines recommend, but then talk about just how much of a problem are patients with highly drug-resistant viruses in the United States today, and then take you on a bit of a history tour of how did we get to the point where we are in terms of how we look at regimens for these complex patients. What were some of the challenges in studying drugs in these situations, and what was the solution that the research community, including the FDA and community activists and academic investigators, came up with to try and find a better way of demonstrating that drugs or new drugs may be effective in what we sometimes refer to as salvage therapy, and then talk about the two newest drugs that have been approved. So these are my disclosures. So as Mike reviewed, the DHHS guidelines for managing patients who have virologic failure are first to evaluate adherence, to look for drug interactions, to assess the tolerability of the regimen, because very often challenges with adherence are driven by poor tolerability of the current regimen, and to gather as much information as you can about resistance to prior treatment regimens and resistance to the current failing regimen. And the goal, of course, is to reestablish virologic suppression with a new regimen that includes at least 2 and ideally 3 fully active agents. And with the caveat that adding just a single new drug really should be avoided, if at all possible, because of the concern that giving just one new drug is tantamount to virtual monotherapy, because if the other drugs are not working, then you're really using only a single active drug, and you risk losing that drug by the emergence of drug resistance. And this concern around the loss of the single remaining new drug is really what drove the FDA to change the way in which it allows testing of drugs in highly treatment-experienced patients. And we have to acknowledge that for some patients, those who are really highly experienced with extensive resistance and with perhaps problems with tolerability to many other drugs that are potentially available, that achieving full virologic suppression may not really be possible. And in those cases, the goal is to minimize toxicity, preserve CD4 count, delay clinical progression by achieving whatever degree of virologic suppression is still attainable. So just how much of a problem is multi-drug resistance today? These are data that were collected by Ron Kagan, who works at one of the diagnostic labs, and so they really get a huge cross-sectional view of resistance in the samples that are sent to them for testing. Now, of course, many of these may be specimens from people who are starting on antiretroviral therapy, and many of them are going to be people failing therapy. They don't really have the clinical histories on all these samples, so they just have the aggregate data. But what you can see is that back in 2006, around 30% of people had resistance to the non-nukes, and about a quarter had resistance to a nucleoside. There was about 15% resistance to the PIs, and of course the integrase inhibitors weren't yet available. But over time, resistance to drugs in each of these classes has diminished, and if you look at those who have multi-drug resistance, here the graph on the right-hand side has it divided up by single, dual, or triple class. And what you see, first of all, in the squares is that the group without resistance is increasing. So an increasing number of tests being submitted to the commercial lab or the reference lab for testing at the time of failure are actually samples of people who are failing without resistance, presumably because of adherence challenges. There has been an increase in resistance to single agents, but fortunately, this is a tricky pointer to learn how to use, but the percentage of people with triple class resistance is really diminishing and is well below 10%, is actually just around 1 or 2% as recently as 2017. Now, even though, so we can be very pleased that our current therapies are establishing virologic control in a large proportion of patients who are in care and on therapy, and those who are failing are generally doing so without accumulating multi-drug resistance. But there is a group of patients, this core group, who really have severe challenges in finding a regimen that will be successful. And beyond drug resistance, it's important to keep in mind that there are reasons other than resistance why certain drugs may not be appropriate for particular patients. And so hence the term complex patients and the need to find new regimens and new drugs for these patients. So now I want to take you back 15 or 20 years and talk about what did we used to do to try to demonstrate that a new drug was effective in patients who were failing therapy. And the standard approach was to do a randomized clinical trial where you took people who had evidence of resistance to 2 or 3 classes of drugs. So back in this era, it would have been resistance to the nukes, the non-nukes, and the PIs, and then randomize them to the new drug or a placebo and allow them to optimize the rest of their regimen, what we call their background regimen. So OBT was not off-track betting, but optimized background therapy. Only New Yorkers understand what OBT is, right? And then to carry out the study for 24 or 48 weeks. And of course, when raltegravir was introduced, this study published in the New England Journal with Roy Steigbügel as the lead author showed a dramatic improvement in the proportion of participants who could achieve full virologic suppression compared to the placebo. There were 2 problems with this approach. First of all of these people were using up their last best drugs and not getting the new agent and developing resistance to the remaining drugs in their regimen. Secondly, as these individuals experienced virologic failure, they then came out of the study or crossed over to receive the investigational drug. And so you had actually a diminishing population in the placebo arm over time, and the further out you went, the less useful the placebo group was, particularly for being able to compare safety and tolerability of the new drug compared to the placebo. Similarly, with boosted darunavir, same kind of trial design, and when people went on the boosted agent, you can see, I'm sorry, this is just showing here people in Power 3 just got boosted darunavir. The earlier studies were randomized, and you can see that 65% were able to achieve a 1 log reduction, and over 24 weeks, 40% got to below detection. And then the first innovation that came along in looking at how we do studies in this population was to permit the use of another investigational drug in the context of a trial for a different drug. And so the duet studies that combined allowed the use of darunavir, which was not yet approved at the time but available through expanded access, together with etravirine, which was the investigational drug being studied. But otherwise, this study was similar to the raltegravir trial in being a randomized placebo-controlled trial with optimized background therapy, in this case called the background regimen. These are pooled data from the 2 similar studies that were done, and again you see that using the new drug together with an optimized regimen gave a substantially greater proportion of virologic success compared to those who received the placebo, but the success was dependent on being able to have other active drugs in the regimen. And perhaps, so you go from 46% when there are no active drugs in the regimen to 78% when you're able to include 2 other active drugs, so you really now have a 3-drug regimen. And then if you took all of those new drugs, raltegravir, boosted darunavir, and etravirine, and combined them into a single regimen, you could do really very well. And this was the TRIO study, which showed that you could get up to 90% success by using 3 completely novel drugs in highly treatment-experienced patients. So again, given the right tools, you can really achieve success. And as we've all experienced in the last decade of having these new drugs, the vast majority of our patients can now be successfully treated despite prior experience. And it may not be necessary to include drugs that have other toxicities or that for which resistance may be existing. And so Karen Tashima and the AIDS Clinical Trials Group did the option study where patients were randomized to receive at least a 2-drug regimen with or without nucleoside RT inhibitors. So if you could construct a regimen that contained at least 2 active drugs, then you could be included in an arm that did not receive nucleoside RT inhibitors, and there was absolutely no difference in outcome. So, and then I'm sorry, before going to the new trial design issue, so then the Viking study, which looked at dolutegravir, the first of the 2nd generation of integrase inhibitors, in this did a trial where they looked at 2 different doses of dolutegravir in patients who had previously failed on a raltegravir-containing regimen and had a range of raltegravir resistance mutations. And you can see that the open triangles were the 50 milligram once daily arm, and then a second arm or cohort was enrolled that gave the drug twice daily. Here's the dolutegravir susceptibility mapped out against different mutations, and the more mutations you had, the higher the level of resistance to dolutegravir. As it turned out, most of the people in the twice-a-day arm actually had virus that was somewhat more susceptible to dolutegravir than in the once-a-day arm, which makes interpretation of the study a little bit challenging. But what was found is that in the twice-daily arm, they achieved about a 1.75 log reduction, which was a little bit better than in the once-daily arm. And if you looked at the proportion who achieved virologic suppression, it was 75% in the twice-a-day arm versus 40% in the once-a-day arm. And if you looked at suppression to less than 400 copies, the numbers were slightly better. But again, success was dependent on having other drugs in the background regimen. There was only a single participant in the twice-daily arm who had no other active drugs, and that person did manage to achieve suppression. But in the once-a-day arm, only 1 out of 12 did, whereas 6 out of 8 did if they had other drugs to help. So this, the reason to provide this background is to understand that, so that was not a terrific way of doing these trials, because what you really want to know is how active is the new drug against the patient's virus, and then if we can lock in that activity by optimizing the regimen, if we continue to dose the drug over time, how safe is it? And what, after consultation with many of the stakeholders, and this is really a discussion that was facilitated by the Forum for Collaborative HIV Research, Veronica Miller's group, and involved Jeff Murray and Kim Struble from the FDA and Trip Gulick and others from the investigator community and also community representatives, came up with this approach for doing so-called salvage therapy studies. You have a group of people who are failing or on a regimen or have a history of treatment failure with drug resistance, and you have a brief period, 10 days to 2 weeks, and in reality it's been shortened to just about a week, where you have everybody stays on their regimen, they get the new drug or placebo, and then everybody optimizes the therapy at day 8 and gets the new drug. So that it's a very short study, it's only a week-long study, and then the rest of the time is really to see how durable is the activity and how safe is the drug. And this minimizes the risk of developing resistance to the new drug, and importantly, it minimizes the risk of developing resistance to the remaining drugs that might still be available to the patient because they don't optimize their regimen until the end of the placebo control period, when now everybody has access to the new drug. So the first first drug to make use of this approach, and one of the 2 new agents available for complex patients, is the monoclonal antibody Ableism AB. This is an antibody that was actually initially isolated from mice. It is an IgG4 subtype, and it recognizes the second domain of the CD4 molecule. So it doesn't bind to the virus, it binds to CD4 cells. And it inhibits post-binding entry of the virus. It doesn't stop the virus from binding to T cells, but it prevents the next step in entry so that the virus is unable to interact with the co-receptor. This is a model based on X-ray crystallography data of the antibody bound here to CD4, and this is domain 2, and that's the region where the epitope that is recognized by Ableism AB can be found. So 15 years ago, I was involved in the phase 1 study where this was a typical single ascending dose trial where participants got one dose at different levels of antibody, and you can see that up to about a 1.4 log reduction in virus load was achieved by this infusion, so substantial activity of the antibody. And more recently, a phase 3 study was completed, which was a variation on the design proposed by the FDA in that paper I showed you a moment ago. So here what they did was to have a period where participants were screened, and then they had a control period. This was a single-arm study. So everybody had a period during which they were monitored for fluctuations in virus load, and in case people started to become a little more adherent to their drugs, or if they were just day-to-day things happening. And so they could see what was the natural biological variation over a week's period in the virus load. And then everybody got a loading dose of ibulizumab intravenously, and then 14 days later, they optimized their background regimen and then were followed for the next 6 months in order to look at durability and safety and tolerability. The primary endpoint of this study was at day 14. The study enrolled only 40 participants, which is really a big surprise for a phase 3 study. We're used to having 700 patient trials where 350 people are randomized to each arm. But this is, again, a novel design for urgent need of salvage therapy in a highly experienced group of patients. And what you can see is in the control period, only a single individual had a half a log reduction. Whereas during the functional monotherapy period, 83% of the participants achieved at least a half log, and 60% achieved a log reduction, with the average log reduction being just a little bit over 1 log and compared to no change, of course, during the control period. And so here, every patient served as their own control. The change after being given ipilimumab was compared to that lead-in period, and that was, not surprisingly, a highly significant difference. If we look at the data a different way, and I'm sorry that the graphs are a little bit small and even up close a little bit fuzzy. If you look at here the data are being stratified by baseline CD4 count. So in the gray bars are those achieving less than 50 copies, and the reddish or brick-colored bars are those who achieved less than 200 copies. So in the intention to treat population overall, about 45% of participants got to less than 50 copies. That was a smaller proportion if they had very advanced disease with less than 50 CD4 cells, but up to 65% or so if they had CD4 counts that were 50 or above. And then if you look at the change in T cell count, again by CD4 grouping, overall, there was about a 60 cell increase in the entire population, about a 20 cell increase in those who started with the lowest CD4 count, and about a 75 cell increase in those who entered with 50 cells or higher. You can develop resistance to ipilimumab, and these are data that come really from the phase 1b trial where patients or participants received multiple doses, and the resistance looks very much like the type of resistance that's seen with other entry inhibitors such as Maraviroc. That is, you don't see a shift in the IC50, but you see a reduction in the maximum percent of inhibition. You see the inhibition curves flatten out, and the folks at Monogram are the ones who did most of the work to try and tease this out. And what they determined was that there are mutations in one of the variable loops of envelope, the fifth variable loop, or V5, where two particular residues that ordinarily have sugars attached to them are mutated, so the sugars are lost, and then the antibody no longer then the interaction is different. And even though the antibody is interacting with CD4, the loss of these sugars on envelope now allowed the viral envelope to interact with CD4 in a way that is no longer affected by ipilimumab. Well, let's turn to talk about the other new drug, also an entry inhibitor, but a unique class of entry inhibitor, and that's fostemsavir, which is a prodrug of temsavir. And so this is a first-in-class attachment inhibitor, and in contrast to ipilimumab, this drug interacts directly with envelope and prevents binding of envelope to CD4. It is active against all kinds of viruses, whether they're R5 or X4 using, or whether they're dual tropic, and it's synergistic or additive in combination with other antiretroviral agents. And here you see the chemical structure. It's just this phosphate group is cleaved off to give you the active drug temsavir. So the BRIGHT study, which was the phase 3 trial of fostemsavir, was actually led by Mike Kozal, who spoke to you before, and so all questions about this trial can be deferred to Mike in the discussion period. But this study took a different approach. This was a much larger study than the ipilimumab study, and it had two different cohorts. There was a randomized cohort and a non-randomized cohort. And the design here was conceived with the understanding that there were many people who had no remaining treatment options. And those people really needed essentially compassionate use of ipilimumab. But if you had other remaining options, then you could create an optimized background regimen, and those people would go into this randomized group where they were randomized 3-to-1 to receive fostemsavir, so strongly favoring early administration of the investigational drug. And here people received either in a blinded fashion, either fostemsavir or placebo, while remaining on their failing regimen for just 8 days. So the primary endpoint here is at day 8 to see how much of a reduction in virus load would fostemsavir by itself achieve. And then everybody optimized their background regimen, and everybody was given fostemsavir. So those in the placebo group crossed over to receive active drug, and then were followed in this open label phase for the duration of the study. I'm only going to present the 24-week data, but there have been longer term follow-up data presented. And then in the non-randomized cohort, again, since this was essentially a compassionate use cohort, everybody got fostemsavir from the beginning and could optimize their background regimen from the get-go. But these people really had no remaining active classes. So they could essentially rearrange the deck chairs, but there wasn't much that they could do to improve their background regimen. This slide gives you a sense of just how treatment experienced the participants in this trial were. You can see that virtually all of them were experienced to the nukes, non-nukes, and protease inhibitors. And in the randomized group, 75% were integrase inhibitor experienced. And so at least 25 of them had available as a new drug one of the integrase inhibitors, but in the non-randomized cohort, 95% were also integrase inhibitor experienced. And there was a moderate amount of experience with Maraviroc, the CCR5 antagonist, and strikingly, particularly in the non-randomized cohort, 70% had used enfuvirtide, or a fusion inhibitor, which is really pretty remarkable. I can't remember now the last time I actually prescribed enfuvirtide. In fact, the last time I prescribed enfuvirtide was to a participant in this trial who enrolled at Yale, thanks to Mike. And then if you look at what drugs were active in the background regimen for the randomized cohort, just under half had a single agent available, about 40% had 2 agents available, 10% really had no agents available, and there's some details about how it is they actually ended up in the randomized cohort, even though they technically had no available drugs. Whereas in the non-randomized cohort, 80% had no other drugs available, and 20% had something available. So how did the drug do? You can see in the primary endpoint at day 8, there was about a 0.8 log reduction in virus load by the administration of fostemsavir compared to placebo, where there was about a 1.17 log reduction, essentially a noise, and this was highly statistically significant. Just under half of the participants achieved at least a 1 log reduction. And if you limited the analysis to those who entered with at least 1,000 copies, where you could really measure a substantial reduction in virus load, the median decrease in virus load was 1 log, and half of the participants achieved that degree of viral load reduction. If you look out over time then, you can see that in the randomized cohort, about 57% of participants by week 24 had achieved less than 40 copies, and 85% had suppressed to below 400 copies. And in the non-randomized cohort, between 40 and 50% achieved the virologic endpoint, depending on exactly where you want to draw the line. And what is notable in both of these cohorts is that the slope of these lines is continuing to increase. So over time, more and more people are becoming virologically suppressed, which is an interesting phenomenon that's still being explored. There was also a substantial increase in CD4 count. Here in the randomized cohort, over 24 weeks, there was a mean increase of about 90 cells, and in the non-randomized cohort, about 40 cells. That's substantially greater than what was observed in the Ableism AB study, if you'll recall. And in the trial overall, about 20% of the participants experienced some serious adverse event, but it's really hard to know whether this was drug-related or non-drug-related. Diarrhea and GI upset and other symptoms were the most common adverse events, but most of these individuals were also on boosted protease inhibitors, and again, we only have the 8 days of placebo control, so it's very hard to know. The main challenge with this kind of trial design is you really don't get a randomized comparison of safety and tolerability. So let me end and summarize again by reminding you that the goal of treatment for patients with complex histories is full virologic suppression, that new drugs with novel mechanisms of action increase options for constructing useful antiretroviral regimens that contain 2 or more active drugs, but that when full virologic suppression cannot be achieved, regimens should be designed to minimize toxicity, preserve CD4 count, and delay clinical progression. And I'll stop there and thank you for your attention.